for joining our second of three Q&A sessions for Central Health's 2020 demographic report. If you weren't able to attend the first one last Friday, you can find the recording on our YouTube channel. Just simply search for Central Health on YouTube and you'll be able to see that video. My name is Ivan Davila and I'm the Director of Communications and Community Engagement at Central Health. We are live streaming this session on Facebook once again. For those of you who RSVP'd and were able to join us via Ring Central, either by video or by phone, you will be muted until about 11:40 when we open it up for questions. If you're joining us by video, please feel free to drop your questions in the chat box. We will answer them as we go or during the Q&A time allotted. If you're joining us by phone, please hold your questions until we open it up for questions. To unmute your line, you can just simply press *6. I'm hearing some, here we go. We're gonna go ahead and mute everyone for now. In the spirit of inclusivity and to ensure the efficiency of the meeting, we strongly encourage our attendees to ask one question or make one comment at a time. And if we don't get to your question, we will have our experts address them and we will send those to all of the participants in a follow-up email. Again, we will use the mute button throughout the meeting and during the Q&A time allotted to ensure only one person is speaking at a time. We ask that you raise your hand if you have a question during the Q&A time allotted, and we will unmute your line. For those of you joining via Facebook, we'll do our best to address your question in a timely fashion. Thanks again for joining, everyone. With that, we'll go ahead and get started. Central Health is the local healthcare district that ensures Travis County residents with low income can get quality healthcare. We are primarily funded by local property taxes. We were created in 2004 by Travis County voters. We are a separate political subdivision of the state of Texas. We rely heavily on demographic and clinical data as well as public input to ensure that our strategic priorities and budget align with the healthcare needs of our community. One of the leading tools that we use to collect and report data to guide our work is our demographic report. So last Friday, we introduced the demographic report during our Q&A session that we held last Friday. And we also talked about data trends around poverty over the course of the last 10 years in Travis County. Today, we're going to talk about access to healthcare in terms of enrollment and utilization trends. And then next Friday, we'll be talking about chronic conditions and burdens of disease. With that, I'm going to go ahead and introduce our panel of experts or speakers. Sarita Clark-Leach is our Director of Analytics and Reporting, and JP Eichmiller is our Senior Director of Strategy and Information Design. JP and Sarita. JP, are you there?
Hello, can you hear me?
We can hear you now.
Thank you. Thanks for the introduction, Yvonne. I'm going to give a quick review from last week. So if those of you who were last week may have heard this already, but want to give you a brief overview of what the 2020 demographic report is all about. This is our third iteration of this report. We presented our first report in 2015, and that one focused primarily on families in poverty, as well as the racial demographics of the overall Travis County population. That report was limited, however, in that we didn't incorporate any of our own patient-level data. In 2017, we presented our second report, and in this report, we began to focus in on specific neighborhoods that were experiencing high levels of poverty. We identified 9 focus areas with high concentrations of poverty. We provided demographic analysis as well as some measurements related to social determinants of health. We also, for the first time, presented some patient-level data related to diagnosis and treatment of chronic conditions. So in the 3 years since that last report, our ability to analyze and report on data has grown exponentially. As you'll see, we're able to provide a much deeper analysis than our previous reporting. And this includes analysis of total population and counts of families and households in poverty, changes in poverty, excuse me, over the past 20 years, as well as 5-year projections. We also have a demographic and geographic analysis of the residents we enroll and the patients we serve. And we have new data points detailing the burden of chronic diseases within Travis County neighborhoods. We've also included data regarding transportation access and insurance coverage to provide additional perspective on factors that affect our patients' health. So I want to do some base setting here before we go forward, just to help everyone kind of understand what some of the terms we're going to be using in today's presentation. First, I want to start with this term, federal poverty level, or FPL, as is often used. These are annual income guidelines that are used to determine eligibility in assistance programs. It can be anything from medical coverage to food, SNAP or food programs, housing as well. And again, this is set by HHS every year. So the 2020 numbers for an individual is $12,760. So individuals earning less than that are considered to be living in poverty. And just to give you some perspective, Sarita and I were looking at our central health numbers of our enrollees yesterday, and the largest bucket of enrollees we have are earning less than 21% FPL, which is equivalent to about $2,670 a year in income. Enrollees. So when we speak about enrollees, we're talking about people that have been signed up to one of our funded programs. Probably the most well-known one is MAP, or the Medical Access Program. And this covers primarily Travis County uninsured residents who are at or below that poverty level we spoke of before. Last year, we rolled out a new program called MAP Basic. This goes a little bit higher income level. We can cover uninsured residents up to 200% FPL, or double the poverty level. And we also count enrollees as those who have signed up for sliding fee scale programs, which are for uninsured Travis County residents who go seek care at one of the FQHC partners we have, which is Community Care, Lone Star Circle of Care, and People's Community Clinic. When we're talking about patients today, what we're talking about is someone who's enrolled in one of those three programs we just mentioned, and that they've accessed either medical, dental, behavioral health, urgent care, or other encounters with a central health contracted provider. So I want to give you a kind of an overview of how this analysis has worked. So what have we been doing with this information, and how does one step follow the other? The first thing we did, kind of the foundation for building a demographic report, was identifying areas of high poverty. That's kind of the baseline, as we saw in the previous slide. It's how we identify who our enrolled and patient population is. It's based on their income. Once we've identified those areas, we cluster them into what we call focus areas. And then we do a demographic analysis. This helps us understand if there's any variances or differences between what's the overall population of an area compared to the people we're enrolling or seeing. And then we've run the numbers as how many within each of those areas have we enrolled in our services, how many people have we gotten into care, how many have we treated, and where are we treating those patients? Are they going to the closest, going to somewhere across town? Finally, what is the burden of chronic disease within those communities? How sick is the community? Is there outliers in certain communities for certain diseases? That's something we're going to be getting into next week. And finally, I just wanted to, this is kind of our next step, aspirational. It's figuring out the whys. We can identify burdens of diseases, or we can identify demographic anomalies in certain communities. But the big question is, why is that happening? And that's really where we're going with the next steps of this report. So just a quick look at census tracts. Census tracts are kind of the baseline geographic measurement that we use in this report. There are 217 unique census tracts in Travis County. These are designed and set forth by the Census Bureau. So the current ones we're using were based on the 2010 census. And obviously, a lot of things have changed in the past 10 years to the populations. You all know Travis County has really exploded with growth. These tracks here in the center, this is kind of the central corridor along I-35, and you can see how they're relatively small. And what happens is the Census Bureau wants all these tracts to be relatively similar in population. So just because these ones are small, they're designed to have relatively even populations as these bigger ones to the east and west. However, what's occurred over the last 10 years is because these small ones don't have much room left to grow, people have been moving into these larger geographic tracts. So what we've had to do and what we're going to be doing when they release the new tracks in 2022 is really carving these big ones up into multiple tracks. So they're going to start to look like these other small ones. And this is important to realize because what may look like it has a large concentration of people or families in poverty today will look much different when it's cut into 4 or 5 pieces. I was telling you kind of those steps of building the demographic report. This is the result we got when we started to look at families in poverty. We identified these 12 focus areas, and these are the areas that have either the highest or kind of next to highest concentrations of poverty throughout Travis County. Again, there's very wide differences between the populations in these areas, as well as the size. Dell Valley, Hornsby Bend, Leander, Manor, these are very, very large areas. So the dispersion of poverty is much greater. Whereas if you look at like North Central Austin, or be considered Runberg, these are very small census tracts with very, very high numbers and concentrations of families in poverty. So this is a look, and this is the first time we've been able to do this at the census tract level of Central Health's enrolled population. And what this tells us, it tells us a lot of things that's interesting. One, we have been doing a fairly good job of enrolling, getting enrollees into our programs in Eastern Travis County. This is Colony Park, these 2 census tracts here, and this is an unincorporated area just to the north of Pflugerville and west of Manor, kind of think of the Tech Ridge area. However, the flip side of that is we've got areas with very high concentrations of poverty where we would expect to see more and higher numbers of enrollment. For example, we only have 1 census tract showing up in Runberg, and we know that that is the most impoverished area and neighborhood of Travis County. Montopolis doesn't show up on this. Nowhere in East Austin does it show up, and we only have 1 census tract from Dove Springs. This is a quick overview of the demographics of our enrolled population. It doesn't trend the same as the overall population. For example, the total population below 18, our children, is about 25% of our overall population, but 18% of our enrollees. This is not surprising, especially among the lower income. You would expect a lot of those kids are getting picked up by CHIP or Medicaid. The same goes with the age 65 plus population. Overall in the county, it's about 11%, but we only get about 33% of our patients. Again, primarily we're getting those folks enrolled in Medicare. The gender trends female, much more than male among our population. And we also have a very large Latino population, 70%, which is about double what the overall Latino population is in Travis County. Whereas our white, Asian, and Black populations are all below what the overall populations look like. I just want to show you a few graphs now. If you think back to that map where these are our 12 focus areas that we showed you earlier. What these white bars represent is the total number of families within each of those focus areas. And the purple bars represent the families in poverty. So you can see again, when we talk about Runberg, North Central Austin, if you just look at the purple areas, just how staggeringly high that number is compared to the rest of the county. And as well as the rate. This is what percentage of families are actually in poverty. And I think a lot of people might not still think that there's areas of Travis County that have that high of a rate of families living in poverty. Same with Southeast Austin, which would be East Riverside, Montopolis. So this graph shows how we are doing with enrolling people within those specific focus areas. In the white, these white bars and numbers, that's the total population of people living within those areas. And the purple bar represents how much of that total have we actually enrolled in one of our programs, be it MAP or MAP Basic. And this is where the trends, you know, where we're trying to learn some lessons or figure out what could be going on and why. If we went back to the previous slide, these first three areas have relatively even populations living in poverty. But we start to see some variances when we're talking about getting people enrolled. Having a much higher number rate in Colony Park than we are in East Austin. And then it's one thing to get people enrolled in our programs, as we know. It's another thing to actually get them into care, get them into services. So this is a measurement of Central Health utilizers. This number, the white bar, that represents how many people we enrolled in a program. And the purple bar represents how many people that we enrolled actually received services during the previous years. So this gives us some interesting information as well. As again, if we look at North Central or Rumberg, by far the largest number of enrolled and even served. But as a percentage, not really doing as good as some areas. For example, Hornsby Bend, if you look at this, not a huge population out there because it is pretty rural and doesn't have a big population, but we're getting a very high rate. Almost 2/3 of the people we enrolled, we were able to turn around and get them into service during the next year or last year. So quick review of our summary findings. Proximity does not equate to access. So many of the areas with the highest rates and numbers of enrollees accessing care do not actually have a physical clinic in their community. And what this means is that proximity to clinics may not impact access as much as we previously thought. Relative to the levels of poverty, what we think we're seeing is that enrollment is below what we would expect in East Austin, Montopolis, and Leander, Jonestown. And this is particularly striking when compared to areas with similar levels of poverty, yet significantly higher enrollment. Finally, the highest concentrations of residents enrolled in our coverage programs, but not accessing services, are in Runberg, St. John's, and Montopolis neighborhoods. Finally, if you enjoy data and if you're listening to this, I assume you probably like listening and learning about. I invite you to check out our new dashboard on our new redesigned website. A lot of the information, numbers we talked about today is on this dashboard. Go to centralhealth.net, hover your mouse above our work, and then click on enrollment, click utilization dashboard. Up next, next Friday, we will be discussing disease prevalence within our communities. And if you would like to read the report ahead of time, again, go to centralhealth.net, hover over our work, and click on 2020 demographic report. And with that, we'd be happy to take any questions you all may have.
Thank you, JP. Before we open it up for questions, I just have one quick question so that we can sort of just set the tone for Q&A. We will we want to focus on the information covered. Can you please shed some light as to how Central Health uses this data, particularly enrollment and utilization information, to plan healthcare delivery, the delivery of healthcare services?
Sure, and I think I'd like to give Sarita an opportunity to chime in. Oh, you're muted, Sarita.
And again, you know, to stress, these data are relatively, even though there are specific numbers here, it's a high-level overview of data that doesn't necessarily answer why for some of the questions that we may need answered in terms of planning for healthcare services. And what they do is prompt a deeper delve or a deeper exploration into those whys to get more of an idea of what the needs are for the community in a certain area or region. So, for example, we can look at things like enrollment in the area relative to utilization, and then, factor in prevalence as well to understand how sick the community is, what they may need in terms of capacity, how large that need is, and what types of services may be needed. So you may have, for example, an area where you see that the population is relatively younger and don't have as many chronic illnesses, and who are enrolled to capacity, with a high rate of enrollment, high rate of utilization. So perhaps the best service for that community might be something in the space of preventative care or just general wellness, whereas you might look at another area that has a higher prevalence rates, an older population, and may not be accessing services, or so again, figuring out what are the specific chronic illnesses in that area that may need to be addressed, what kinds of service in terms of primary care versus specialty care, are there pharmacies in the area? So that's a couple of use cases or ways that we can look at these data to understand how we need to plan for care relative to region.
So chronic conditions play a big role, or disease.
It gives a high level, it gives a high level insight into the health of that population, we should say. But again, that this is only a high level cursory look at that information. We'll talk about prevalence and chronic illness in our next discussion next week. But again, that's just a general application of how we need to look at these data to think about healthcare planning.
That's great. Thank you, Sarita. There's a question that came up in the chat window. What are some of the things that Central Health is trying to do to improve and increase healthcare in the more impoverished areas? Are there any initiatives that are being thought of? And we can talk about some of the work that we're doing in Eastern Travis County, but I'll let you answer, Sarita.
So in terms of work that we're doing, and perhaps it's a little biased, but I feel like everything that Central Health is doing is to serve our impoverished communities. Our population are those who are folks below 200%, at or below 200% of federal poverty income level. And I see Mike on camera here as well, who may be better positioned to talk about all of the different things that we're doing in that space to help the community. And Mike, I hate to put you on the spot.
Everyone, this is Mike Giesling, our president and CEO. Go ahead, Mike.
Hey, good afternoon, everyone, and thank you for joining us. I'm sorry, still good morning. Still 7 minutes left, but no, Sarita's right. If you think about the medical access programs, and one of our greatest strengths that we bring to the equity equation here in Travis County is providing access to healthcare. And that's not only for the medical access program, but also the medical access program basic, which is the successor to the older sliding fee scale programs, and having the outreach. And the second thing is having the level of outreach that goes beyond the digital divide and reaching out to individuals in person, especially through community healthcare workers and other partnerships, to make sure people are aware of the resources that are out there to connect people with care programs, and then when they are enrolled, how to get care. And so that's another very important facet of what we do. Third is stepping back, and I believe our Chief Strategy Officer is also on the line. I saw her name earlier, Monica Crowley, but stepping back and taking a systems-based approach and really looking at this through an equity lens. And it's not just about having a certain number of dollars allocated to specialty care, primary care, hospital care, post hospital care, et cetera. It's being very strategic about where do we need to fill in the gaps to address current and historical healthcare disparities and inequities. That is absolutely essential work that we do here at Central Health, and it's year over year improving upon the scope and level and quality of care that those that are uninsured and below income levels have access to. Fourth, and you all have, those of you that have tuned in to our Eastern Travis County subcommittee meetings or strategic planning committee meetings, you've seen about our work in Eastern Travis County expanding clinical sites for health and wellness centers in Hornsby Bend, Del Valle, and Colony Park. And those are just a few. And so those things, if you take all of what we just talked about here, all of that is targeted to fulfilling our mission of providing access to care to those that need it most.
Thank you, Mike. Monica, did you have anything to add? If not, we can open it up to questions. Did you have something to add? No, we're good. Okay. Is there any? I'd like to open it up for questions. We have a few more minutes, but again, if there are more questions than we have time allotted, then we can definitely follow up. There's a question on the chat box. It says, based on the data presented, I'm wondering about immigrant communities. Potentially, there is uneven awareness of services, some language barriers. Also wondering if nonprofits may have helped some folks get enrolled, but they then enrollees lack the support to know how to make use of services later on. I'll start off, and then I'll let Sarita and Mike and anyone chime in. We do have partnerships with community organizations, including nonprofits, that help us enroll people in services, and we are expanding that community outreach partnerships initiative as well, so that people that are accessing social services perhaps have the opportunity to also not just be aware of our coverage programs, but also get assistance in enrollment as well, and that includes immigrant communities as well. And Sarita and Mike or anyone else, would anybody like to add on to what I'm saying, my response?
Yeah, I would agree with what you're saying, Yvonne, absolutely. And I think to Sarita's earlier point, we are gaining better and looking into understanding more about these populations that we've enrolled as well as served, and identifying where there might be gaps that we need to focus
Thank
on.
you, JP. Thanks. And let me add something to that as well. We have been utilizing community health workers to do some of the outreach, and not just outreach for the sake of awareness in our coverage programs, but also for the sake of enrollment and navigation for enrollment purposes. And so our community outreach and our community health workers and community outreach specialists increase awareness of help people understand what health coverage programs are available to them, and then help them through the enrollment process as well. Mike, did you have something to add as well?
Yeah, and I'll add to that. I really want to underscore just the philosophical and mindset that we bring towards serving immigrant communities. And as Yvonne noted, it's not just about translating things. It is about having trusted sources out in the community that can have a conversation around how to get enrolled, how to access care. Because as you know, and unfortunately, just the negative media and messaging that people have had to endure that are immigrants, and it really just creates a huge challenge, but it's one that we're up to and can continue to overcome, to make sure that people know that we are a trusted source of information, and making sure that people understand that you do have options. You don't have to suffer, and you have caring people there that are willing to help you live a happy, healthy, and productive life.
That's right. Thank you, Mike. Trust is very important, and not just at the individual level with community health workers, like he said, but also just underscoring the importance of our community outreach partners. And if you have any questions about our community outreach partnership program, you can go to centralhealth.net, go to our work, and then there's a link as to how to partner with us. And there's a lot of information there so that nonprofits can can understand the different levels of partnership with us as well. Is there any more questions? I don't see anyone asking any questions on Facebook or on the chat box. I want to recognize our chairperson, our chair of the board, Ms. Sherry Greenberg. Thank you so much for being here.
My pleasure. Thank you. Thank you, everyone, for attending.
Absolutely. Well, with that and not having any more questions, this is posted on this will be posted on our YouTube channel. You can always ask questions on our YouTube channel as well under the comment section, and of course on Facebook via the Facebook Live feature. It'll continue to live on Facebook as well. And if you have any comments or questions, we'll be happy to address them there as well. With that, I want to thank Sarita, JP, again, Madam Chair of the Board, Madam Chair Greenberg for attending, Mr. Gieslin, and Monica, and everyone who attended. Thank you all so much for attending. And we look forward to having you here again next Friday at 11:30, where we will be discussing disease prevalence and chronic conditions for our priority population here in Travis County. Thank you all so very much. Enjoy your weekend.